All right, everyone. As a clinical nurse specialist, I want to talk about a situation we have all faced at the bedside. You've got a hypotensive patient, their pressure's dropping, and what's our go-to? Hang a fluid bolus, right? But have you ever stopped and really asked yourself, is that the right move for this patient at this exact moment? Well, let's dive into that and see how we can get from just guessing to actually knowing.
So let's kick things off with the big problem we're trying to solve. When we give fluids, a lot of the time, it's really just a 50-50 guess.
I love this analogy. Think about it like watering a plant. You see a wilted plant, you give it water, it perks right up. Perfect. But what if that plant's soil is already soaking wet? More water isn't going to help. In fact, it's going to cause root rot. It's the same for our patients. The real question isn't just will fluids raise their blood pressure, but will fluids increase their stroke volume? The amount of blood the heart actually pumps out. Because just like that plant, we can absolutely oversaturate our patients.
And here's the reality check, the hard data. In our critically ill, unstable patients, a fluid bolus only works, meaning it actually increases stroke volume by a meaningful amount, about half the time, 50 to 60%. That's a coin toss. We're basically flipping a coin every time we hang a bag of fluid. We can do better than that for our patients. We have to.
So, how do we get better than a coin toss? This is where functional hemodynamics comes into play. And honestly, for a lot of us, this is the real aha moment. It's how we check the soil before we pour the water, so we can predict which patients are actually going to benefit from those fluids.
And here's the crucial point. This whole approach isn't about staring at a single static number like a CVP reading. It's about seeing how the cardiovascular system reacts in real time to a challenge, like a fluid bolus. It's really the difference between looking at a single photograph versus watching a movie of your patient's physiology. And this right here, this is the why behind it all. The good old Frank Starling curve. The best way to think about this is like a rubber band. When your patient is on the steep part of this curve, their heart muscle has room to stretch. You give them a little fluid, you get a little stretch, and bam, you get a big snapback, a big increase in stroke volume. But if they're already on the flat part of the curve, that rubber band is already overstretched. Giving more fluid does nothing for their output. It just starts backing everything up.
Okay, so how do we actually see this rubber band effect at the bedside? Well, what's so fascinating is that the answer is hiding in plain sight. It's right there in the waveforms on our monitors.
For our patients on the ventilator, the key is the interaction between the heart and the lungs. Every time that ventilator pushes in a breath, it temporarily decreases the preload coming back to the heart. And we can see this effect on our arterial line waveform. We use these variables, like systolic pressure variation, SPV, and pulse pressure variation, PPV, to actually put a number on those changes.
So here's what the monitor is doing behind the scenes, and it's pretty brilliant. It's looking at the biggest pulse pressure and the smallest pulse pressure during one breath, and it calculates the percentage of variation between them. Now, if you get a high number, say a PPV over 12 or 13%, that is a massive clue. It's telling you that the heart is super sensitive to those little changes in preload. It's on that steep, stretchy part of the curve, and it's very, very likely to respond beautifully to a fluid bolus.
Okay, theory is one thing, but let's make this real. Let's walk through a case that you might see tonight and see how these concepts can totally change our decision-making, right there at the bedside.
Using this, we can create a really clear, repeatable algorithm. The logic is so simple. First, do we even have a problem? Are there signs of hypoperfusion? If yes, then we use one of these dynamic measures to see if fluids would even help. If the indicator is positive, we give the fluid, and then, and this is probably the most important part, we immediately reassess. Did our intervention actually work?
So, let's meet our patient. He's a 52-year-old guy, post-op from a ruptured diverticulum that led to peritonitis. He's septic, he's got a history of hypertension, and he's on the vent. I mean, this is a classic setup for some serious hemodynamic instability. All right, let's break this down line by line. At 2 in the morning, his MAP is circling the drain at 60, and his stroke volume is a measly 29. But look at that key number. His PPV is 17%. That number is screaming at us, I'm fluid responsive. So we give a 500 ml bolus. Now fast forward 30 minutes. The results are amazing. His pressure's up, his heart rate is down, and look at that stroke volume. It's almost doubled to 51. But here's the real insight. Check out his PPV now. It's dropped all the way to 8%. He is no longer fluid responsive. The tank is full. So what's the next right move? We can't give more fluid. So as you see here, we start dobutamine to give the heart muscle itself a little more squeeze.
Okay, now these tools are incredibly powerful, but, and this is a really big but, They are not foolproof. We have to be smart clinicians. We have to know when these numbers might be leading us astray and what to do when that happens. See, these arterial-based numbers like ppv, they need a very specific, controlled environment to be accurate. You need a patient on the ventilator, regular heart rhythm, decent tidal volumes. The second you have someone taking their own breaths, or they're in AFib, or they have an open chest, those perfect heart-lung interactions get all messed up, and frankly, the numbers become unreliable.
So what's our move then? We can't just throw up our hands, because we still need to know if our patient needs fluids. The great news is, we have an incredibly simple and really effective alternative. It lets us create a temporary fluid bolus using the patient's own blood.
It's the passive leg raise, or PLR. It's so elegant. You just move the patient from a semi-upright position down flat and raise their legs. When you do that, you shift about 300 to 500 milliliters of their own blood from their legs right into their chest. It's a completely reversible fluid challenge. It's like a test drive. If you see their cardiac output or stroke volume jump by about 10 to 15%, you've got your answer. They're fluid responsive. And this works even in patients with arrhythmias or who are breathing on their own. But like any intervention we do, safety first, always. A PLR isn't for everyone. We have to use our brains. Does the patient have an unstable spine? Is their ICP already high? Do they have abdominal compartment syndrome? In those cases, this is a definite no-go.
And this brings us to what I think is the single most important takeaway from all of this. This quote says it perfectly. These tools tell you if a patient will respond to fluids. They do not tell you that you should give fluids. Our clinical judgment, our assessment skills, that's still the most important monitor at the bedside. We only treat when there's a real clinical need, when we see those signs of hypoperfusion that need to be fixed.
So I'll leave you with this question to think about on your next shift. How can you start using these dynamic assessments in your daily practice? Because by integrating them, we can finally move beyond that 50-50 coin toss and start making the kind of precise, patient-specific decisions that really change outcomes.